Guillain-Barré syndrome. I actually have worked with Guillain-Barré extensively. I worked at New Mexico Rehab Center, and it was a little more common in New Mexico in the oil fields. I think it's pretty common here. I hear a lot of, I don't know exactly if it's more common. I don't know that there's any research there, but I think you have a lot of cases here around this area. Have you ever heard of it?
I treated a person that had even one. I think that's what it was. They get nodules in the knees.
No, Guillain-Barré is where it reacts like MS in some ways, but they just lose all their strength and then they regain it back. It's a virus. And sometimes it'll just be in their hands and feet, and then sometimes they'll actually end up on a ventilator, and they're very sick. Some of them die. So it's a viral thing. It's a lot of fun to work with them because normally they'll completely come back, and so you really see a lot of improvement. It really represents a broad group of demyelinating inflammatory polyradiculoneuropathies. Do y'all know what all that stands for?
No.
What's demyelinating? That they're losing myelin. Inflammatory, you know. What is poly? Many. Radiculo is nerves. Radiculo, it's nerves, but because the neuropathies would be the nerve part. Let's look that one up. And then the pathies would be what? Disease. So it basically many, where you have more than one nerve is what that polyradiculopathies is. Thank you. The lymphocytes infiltrate the interstitium with deterioration of the myelin sheath. And so basically, it just eats away at the myelin sheath, kind of like MS does, but then it comes back, it grows back. So within 2 to 3 weeks, the swan cells proliferate and recovery starts. So normally, if they have a normal bout of it, they'll go in the hospital. Sometimes they don't go in the hospital, but it takes about 2 to 3 weeks for that to kind of resolve. 60% of Guillain-Barré patients follow a respiratory or gastrointestinal illness. It's really weird. It's like they'll have the flu and then they develop Guillain-Barré. It's pretty common that that's the case. And what they'll notice is they'll just have foot drop or something. It's just a weakness in the foot or in the hands. Again, sometimes it just affects the hands and the feet, and it doesn't go any farther than that. Other times they, what did I do? Diagnostic features, motor weakness develops rapidly, like overnight. I had a lady in New Mexico, and she was a walker, and that night she went walking. She was doing like 5 miles a day, and she noticed she had foot drop on one foot. And then the next morning, she could not move to get out of bed. She wasn't strong enough. She became a quadriplegic overnight. Which is scary. When it gets very serious is when it affects their respiratory system and it affects their diaphragm and they can't breathe. So that's when people die. And so they have to go on a ventilator. But she did not get that weak, but she was like a quadriplegic. And it took her about 6 months to even get where she could stay by herself. She was very severe. And she was fairly healthy. She was probably 65 maybe. So it develops its relative symmetry of motor involvement. So normally it's symmetrical. So both hands will get it, both feet will get it. It's kind of a systemic type thing. It's not one side or the other. Progression is distal to proximal, so it starts in their hands and feet. And then they have the areflexia. So it's kind of affects them like a lower motor neuron type thing because of the myelin. Mild sensory symptoms or signs. Sometimes they have sensory issues and sometimes they don't. Autonomic nervous system dysfunction in 50% of the cases, and so they get tachycardia, they get arrhythmias, they have blood pressure issues, and so that sometimes is what kills them. Also, they have to be careful. Absence of fever at onset, but a history of flu-like illness. Nerve conduction velocities are usually abnormal, and that is, again, is the test to check how fast the nerves are working. So it'll be kind of in a peripheral because it's the distal extremities, and so those will be abnormal. Recovery begins 2 to 4 weeks after the plateau of the disease process, and it may limit to distal limbs of upper extremities and or lower extremities, or may extend to full quadriplegia. Death occurs in 5% of cases from secondary problems. So like they get pneumonia because they're on a ventilator or something like that. And so they get so weak, and if they go, anytime you go on a ventilator, it's not good, right? You can't breathe, you're taking chances with your lungs. So that's why they're trying to keep COVID patients off of ventilators. They think they've killed some of them putting them on ventilators. So I'm not laughing, it's a horribly serious thing. And so it's bad to have to go on a ventilator. Prognosis, 50% show minor neurological deficits, and so they recover. So they have foot drop, decreased fine motor skills in their hands, they're just real clumsy. 15% show persistent residual deficits in function. So 15% of them do not recover 100%. So you'll see some foot drop. They have to wear AFOs on their ankles because they have foot drop. Or they end up walking with an assistive device because they don't get their glutes back. The glute maximus and medius is really affected. Approximately 80% become ambulatory within 6 months of onset. So it can be very severe and affect your life for years before you completely recover from it. So. I guess we ought to all go get coffee if you want to.
He was standing in line, he said he wouldn't be late for class.
I was still late a little bit.
There's the coffee cups to you, so we'll get out real quick. There's not much more, I mean, this is fairly short. The things that you need to remember about this one particularly are these common long-term deficits, because this is what you see. You see weakness in the anterior tibialis, so the dorsiflexion is affected, so they have to wear AFOs. Sometimes you'll see weakness in the foot and hand intrinsic, so again, they don't have good fine motor. Or you see weakness of the quadriceps and gluteal muscles. So here are people who can walk and they go home, but they can't get up and down from the toilet because they can't stand up. But once they're up, they can walk, but they can't get up and down. It's a mess. So you have to work with them, getting them on a sliding board because they literally don't have the the glute strength to stand up. Patient will have a duck walk if the gluteal muscles are involved, and almost all of them are. Patients often can walk before they're able to get up and down from a chair, which is what I just told you. A duck walk is kind of like a bilateral Trendelenburg. What's a Trendelenburg?
Hip drop.
Where you have hip drop on the opposite side. You like to have weakness on the left and you have hip drop on the right. What these guys do, because their glutes are really weak, is they have hip drop, but they also turn their feet out. So they'll lock their knees in, and then they go to this one, and it's kind of a weird, it's called the duck walk. But they kind of go both sides, and first time they walk.
Walks like that when you really get going.
Pardon?
Corey walks like that when you really get going.
There you go.
Want me to demonstrate?
So anyway, you can put duck walk down there because that is a common thing that goes with Guillain-Barré when they first start walking. You see them go into that, and hopefully those will come back. And what do you want to do in that situation if you see somebody duck walking?
Correct it.
You want to correct it. You might put them into some knee braces because you don't want their knees to buckle on them because they're locking those knees in to keep that quad. So you really need to look at it, because if you allow, it's just like with a limp. If you don't let them off of an assistive device if they're limping, because they're going to limp the rest of their life, right? So the same thing, if they're doing an incorrect gait pattern and you're hoping that they're going to heal from that, then make sure and try and work them out of it. So your goals in acute care are to facilitate resolution of respiratory problems. How are you going to do that? They've been on a ventilator. What are you going to do with them?
Breathing too.
You're you're gonna teach them diaphragmatic breathing, aren't you? You're gonna teach them pursed lip breathing. You're gonna teach them to do endurance stuff. You're gonna start with them just increasing their activity little by little. So you want to improve the respiratory. Prevented cubitus ulcers, this actually can be an issue with these guys. But again, normally they do not have a lot of sensory loss. And if someone doesn't have sensory loss, they're not gonna break down normally. Even an old person, if they have good sensation, they're gonna move off that spot, aren't they, if it starts to hurt them. But if they do have sensory loss, that's when they can develop ulcers, bed sores. Minimize pain as much as you can. Prevent contractures. Believe it or not, they can go into contractures in their feet and their hands before they get that muscle power back, so you don't want any kind of contractures. Prevent injury to weakened or denervated muscles. How can that happen? They can pull a muscle if you overwork it. So these guys, when you first start with them, they're gonna be one that you treat 4 times a day for 10 minutes each, rather than 2 times a day in a hospital. Because that's all they can tolerate. If you overwork a Guillain-Barré patient, you can cause them to go into an exacerbation. So you never want, if they tell you they're tired, you let them rest, because they're wanting to get well. Nobody wants to stay that weak. But always know that you can cause them to go into an exacerbation, so you don't overwork them. That's true with MS patients too, by the way. You do not want to overwork them. So you want to prevent injury to weakened or denervated muscles. Facilitate muscle contraction while monitoring overuse and fatigue. There you go. Watch for overuse damage. It can cause regression. Short session with increased frequency. I just said that, didn't I? I probably in my career have worked with 20 to 25 Guillain-Barrés, and most of them were in New Mexico before I ever came here. And they were all ages. I worked with a kid that was like 13. We had a little girl here that had it when she was 2. Do y'all know Jennifer Marvin? Jennifer Marvin had it when she was a little bitty girl. And you can't even pick up on anything with her. The only thing that happened with her is she actually had some damage to her shoulders. They put her in gymnastics to kind of build her up, and probably a laxity in those shoulders from things. And so, her mother did everything she could. But just to watch her walk, I can't pick up anything on her anymore. But she did have to have both of her shoulders dislocated. So they had to do some work on her shoulders. But she's doing great. But when she was 2, she was like a quad. She couldn't move. So we worked with her quite a bit.
How do you get it? It's from a virus.
It's a virus, yeah, it's viral.
Just like any.
Well, and it seems to follow again some type of flu bug, and if your immune system is down, and it's just, how did Jennifer, I mean, I don't know how that little girl got it. I mean, she comes from a good, healthy family, and so, you know, viruses are weird, aren't they? Just like COVID. Why do some people get COVID and others people don't? It's kind of the same type of thing. Who said they worked with the Guillain-Barré?
Yeah, I was wrong.
Okay. I see them in home health, you know, occasionally. Treatment, you want to use short periods of non-fatiguing exercise matched to the patient's strength. So this is one that you don't push them heavily. You know, you need to be a little more conservative. Increase the difficulty of an activity or level of exercise only if the patient improves or if there is no deterioration in status after a week. You really can see them decrease in muscle strength. So if that happens, you're probably going to just quit cold turkey for a little while, by the way. Return the patient to bed rest if a decrease in strength or function occurs. So again, you're going to just let them rest. Direct the strengthening exercises at improving function, not merely at improving strength. So the little boy that was 13 was like a quad. These I all saw in the rehab center where I worked there in Roswell. And he got so weak. I mean, he was like a quad also. And it was about 6 weeks before we ever got him where he did very much because he would exacerbate. So we had to lay off for a week and then and that's when you could keep him in the rehab at those times instead of sending him home. But he played, in a year's time, I think he was playing baseball at school, so he really recovered very well also. So I remember him coming and seeing us in his baseball uniform, so. Okay, any questions on Guillaume Gray? Monday, we start on wounds, and so just come prepared to take a lot of notes, with her. I have the PowerPoint on there if you wanna look at it, I'll open it up so you can look at it a little early. But she's gonna bring you, what we do on the first session is talk about wounds, venous wounds versus arterial wounds. Any of that you've had, you might review. She's gonna show you tons of wounds, stage 1, 2, 3s, and 4s, so you can kinda know what that is. And then on her second session, she's gonna bring you all the different types of treatment for it. Whether you put a dry dressing on a wet wound and all that kind of stuff. And so when you use a certain type of, like if you use a piece of foam, when would you do that? And that kind of stuff, to kind of have an understanding of just basic, different types of wound treatments. So it's pretty good. You'll enjoy her. She's a lot of fun.